Hello, everyone. Welcome to today's Better Care Playbook webinar on the Caring for Caregivers program, Practical Approaches for Improving Caregiver and Patient Outcomes. This webinar is made possible through the support of the Seven Foundation Collaborative. My name is Logan Kelly. I'm a Senior Program Officer at the Center for Healthcare Strategies. And before we get started, I would like to quickly just go over a few logistics. To eliminate background noise, audio lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. And we can go to the next slide and you'll just see that there's information about how to submit a question online. You can do that at any time by clicking on the Q&A icon, which you'll see at the bottom of your screen. And today's event will be recorded and it will be shared publicly on bettercareplaybook.org. And you'll be able to download the slides and watch the recording as well. And then finally, at the end of the webinar, we just ask that you complete the brief online evaluation that will pop up on your screen. We really appreciate that feedback. So we can go to the next slide. And again, welcome everyone who is just joining us. We're really excited about today's webinar. It will focus on the Caring for Caregivers model. This program was developed by Rush University Medical Center, and the model applies evidence-based strategies to address caregiver burden and to improve care for older adults and caregivers through education, resources, and support. And this webinar is a part of the Better Care Playbook Implementation Lab series. So all of these sessions really aim to explore implementation strategies for specific models that have demonstrated evidence, such as caring for caregivers in today's event. In the first part of the webinar today, we'll hear from our presenters, and then in the second half, we'll have ample opportunities for everyone joining to ask the questions that are on your mind about caregiver programs. And we hope that this webinar helps you understand the structure of and the evidence behind this program, the landscape for supporting caregiver programs, and then insights on how you could apply these lessons on implementation in your own settings. And on the next slide, I'll just quickly highlight the agenda for today's webinar. We'll start with introductory remarks about the landscape and importance of programs for family caregivers. And then we'll be joined by a team of presenters with a range of experience developing, implementing, and participating in the Caring for Caregivers program. So we'll first hear from a team at Rush University Medical Center, and then hear more about the context for deciding to implement this program at Grady Health in Atlanta. We'll follow that with a moderated Q&A session. And again, we just really encourage everyone to submit questions as our speakers are presenting. And then on the next slide, for those of you who might not be familiar, the Better Care Playbook is an online resource center for evidence-based and promising practices to improve care for adults with complex health and social needs. And so every month, the playbook summarizes new evaluations, implementation tools, and journal articles, and also develops resources like this webinar that are really designed to translate from the evidence into real-world experience and practice. And you can explore the playbook at bettercareplaybook.org. Next slide. And so the playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading national healthcare foundations: Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. And on the next slide, I'm pleased to introduce today's presenters. They include Dr. Gabriella Cohen, who is working to implement the Caring for Caregivers program at Grady Memorial Hospital, and also serves as assistant professor in the Division of Geriatrics and Gerontology at the Emory University School of Medicine, and is a provider with Georgia Memory Net. The team at Rush University Medical Center includes Robin Golden, who is the Associate Vice President of Social Work and Community Health, where she holds faculty appointments in medicine and chairs the Department of Social Work in the College of Health Sciences, among many other roles. Diane Mariani is the program manager for the Department of Social Work and Community Health at Rush University Medical Center, and manages the Rush Caring for Caregivers program. Vivian Joy Lamadrid is a nurse on the medical intensive care unit and serves a number of roles to support nursing staff work-life balance. Vivian Joy is also a family caregiver that has benefited from participating in the Caring for Caregivers program at Rush. And then our first speaker today will be Ronnie Snyder, who is Vice President Program at the John A. Hartford Foundation, which is a private philanthropy with a vision of a nation where all older adults receive high-value, evidence-based healthcare, are treated with respect and dignity, and have their goals and preferences honored. So we can go to the next slide, and I will welcome Ronnie to begin by providing some introductory remarks. Welcome, Ronnie.
Thank you so much, Logan. That's a great setup. Yes, I'm Ronnie Snyder. I am the Vice President for Program at the John A. Hartford Foundation. I'm here today with my colleague, Nancy Wexler, who works on this project because we're really excited to share more about it and hear more about it with you. So thanks to everybody who's here on this Better Care Playbook webinar that is featuring what we really think is an incredibly important topic: how health systems can achieve better outcomes by using evidence-based approaches to care for family caregivers of older people. We ourselves have actually been, as Logan just outlined, a really proud supporter of the playbook since its inception, and we encourage all of you to use its valuable resources for improving complex care for many people, older people and beyond. And today, you get the pleasure of hearing from the Rush University Medical Center team and its Caring for Caregivers, or C4C model. This is a program that we support and one that we really think that all health systems need. And we're so grateful to hear as well from Atlanta's Grady Health System, a C4C adopting site. And then even more grateful to hear from a caregiver herself. So Vivian Joy La Madrid, which is so important to do whenever we think about any of these kinds of programs. Logan mentioned we, the John A. Hartford Foundation, are a nonpartisan national philanthropy with a mission to improve the care of older adults. And to do that, we work in three primary areas: building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. So you can hear that this is touching on all three of our important programmatic areas. So why do we focus on family caregivers? We do that because we know they're the backbone of care for people in this country. Typically, caregivers don't get the support that they need, especially in healthcare, but we're working to change that through support for policy change and by spreading programs just like Caring for Caregivers. So I want to connect today's discussion to two important opportunities that all of you should know about. One of them is related to healthcare delivery and the other to caregiving policy. So first of all, you're going to hear from the Rush team in describing their model. And really part of the age-friendly health systems movement. So our foundation, together with the Institute for Healthcare Improvement, and in partnership with a whole host of others, including the American Hospital Association, are supporting the spread of evidence-based care for older people that reduces harm and aligns all of our care with what matters to older patients, to their family caregivers as well. So this framework, age-friendly health systems, follows the 4Ms. And that means that clinicians focus on 4 elements, 4Ms of care that are essential to achieving best outcomes. They are what matters to the older adult, keeping that at the top, medications, mentation, which is anything cognitive, anything of the mind, and mobility, which is so much about function. Right now, there are about 4,000 hospitals, practices, nursing homes, and convenient care clinics that have joined the movement to age-friendly health systems and adopted this 4Ms framework. So I want to encourage all of you to inspire the health systems that you work with to join the movement. And you can do that through 7-month action communities that are hosted by either the Institute for Healthcare Improvement, or the next action community is going to be run by the American Hospital Association. And it begins in September. So you got a little time to prepare. You can visit aha.org/age-friendly if you want to learn more about how to do that. So second, related to family caregiving policy, you should know that as of last year, we have, first of its kind ever, national strategy to support family caregivers. It was developed out of legislation passed in 2018. It is a whole of society plan to support caregivers. And at the federal level, more than 15 different agencies have committed to over 350, I'll say that again, 350 actions under 5 different goals. And one of those big goals is to better include caregivers as part of the care team. That's what we're going to talk about today. It's already resulted in important changes, like the Centers for Medicare Medicaid Services for the first time paying clinicians for time that they spend educating family caregivers in their caregiver role. So a one-year report to Congress on the national strategy is going to be released in a little over a month. And that strategy calls on every one of us to take action and to advocate for this and more change. So please follow along. Link your work to support caregivers to the national strategy and also to what Rush will be talking with us about today. We're going to be sharing a lot of information ourselves at the foundation about this forthcoming one-year report. So you're welcome to subscribe with us as well at johnahartford.org. So let me end there. I just want to thank the Playbook team, the Rush team, and all of you for supporting family caregivers as part of improving patient care. We hope that you'll use the resources from our foundation, from the Better Care Playbook, and that you'll encourage adoption of this C4C model, as well as participation in the age-friendly health systems movement. So back to the program with my thanks.
Wonderful. Thank you so much, Ronnie. And next I will introduce, I think first, Robin Golden, I believe,
Yes.
and then the rest of the Rush team.
Thank you, Logan. Thanks for having us today. And thank you, Ronnie and Nancy, for that wonderful tee up and for all your support to spread and scale this model. We have had a pilot that has spread and scale in quite a few acute care ACE units, primary care, caregiver resource centers, hospitals, inpatients, skilled nursing, you name it. So thank you for that. And thank you first to the RRF Foundation for Aging for providing funding for us to create this and fully develop this model. So we're glad to be here with so many of our partners, as you can see. Can you skip to the next slide, someone? Thank you. Okay, and now to the slide. So here's all our partners, thanks. And now next. So I just want to kick it off reinforcing what Ronnie says. We love quoting Ronnie all the time, but I also love quoting Lynn Feinberg, who really started so much of the caregiving movement in this country. Remember the family. They are our de facto long-term care system in this country, yet we never ask or assess if they're ready, willing, and able. This is really the principle of what C4C is based upon. Caregiving is a critical influencer of health, and as we talk about nowadays more than ever, a social driver of health. Older adults that have family and friends, caregivers fare much better than those who are alone in this care, but being a family or friend caregiver has the opposite effect in decreasing physical and mental well-being. Years of advocacy, next slide, please. Years of advocacy have brought us to a place of increasing recognition of the challenges facing family caregivers and the need to support them. The CARE Act, which a lot of what our program is based on, stands for Caregiver Advice, Record, or Enable Act, and it's enacted in 45 states and territories. It helps family caregivers when the older adult goes into the hospital and they transition home. Upon a patient's admission into the hospital, the CARE Act requires the hospital to provide the patient with an opportunity to designate a family or friend caregiver and enter them into the electronic health record. To inform the caregiver when the patient is to be discharged to another facility or back home, and to provide training on the medical tasks that the caregiver will need to perform at home. Critical, very critical, and Diane will explain more of that later when we discuss the model. Policy actions like the RAISE Act, which was just mentioned, which resulted in the 2022 National Strategy to Support Family Caregivers, and it's now being acted on a variety of ways in President Biden's 2023 executive order that recognizes family caregivers as a national priority and aims to better include and support them through federal programs. There's also so much more discussion in mainstream media, such as the piece last month in NPR that Diane was in, highlighting unique experiences of Black male caregivers and the PBS documentary that'll be coming out with Bradley Cooper, helping to create and talk about caregiving and raise everyone's awareness of how critical the issue is. Go to the next slide. We just know family caregiving is, talked about all over the place. And you can't, I think as Rosalind Carter said, you're going to encounter it some way. You're going to be one, you're going to have one, you name it, you're going to be connected to it. We all need to address it, because either people are sometimes done in by the tasks, or people find them very rewarding and deepening relationships. And when caregivers, though, are impacted physically, financially, emotionally challenging, we know there's room there for intervention, because the rates of depression can be higher, anxiety, fatigue, sleep disturbances, and cardiovascular disease. So it's critical to try to find them and assess for what their needs are. The complexity of the tasks are incredible, what family caregivers are being asked to do. Administering medication, dressing changes, handling complex medical equipment in the home. Despite this, family caregivers are rarely asked, are you able and willing to provide this care? And if you're not able or willing, how can we help you? So I think we're finally recognizing the importance of this. The next slide really just speaks to what Ronnie just said, which is you can't be an age-friendly health system, this is Ronnie's quote, without also addressing caregivers. So we use that quote all the time. So the movement is critical. C4C is part of the movement, and we're very committed to bringing age-friendly and C4C together. CMS recently proposed incorporating an age-friendly hospital measure into the 2025 inpatient quality reporting and 2027 payment too. So that's exciting for the movement. Next slide. So if you think about some of the new physician fee schedule, which is very exciting, and building on the RAISE National Care Act, there is a lot in there about behavior management, behavior modification, functional performance, all those things that are going to be very related to older adults and family caregivers. When the coding applies, when practitioners train and involve one or more caregivers to help patients carry out a treatment plan for certain diseases and illnesses like dementia. For caregiving training services, we define caregiver as an adult family member or other individual who is in a significant relationship with or provides a broad range of assistance to an individual with a chronic and other health condition or disability. So that's what kicks in and makes it more medically necessary. It's amazing that these are becoming, social care codes are established in the physician's fee schedule. That's a remarkable thing. And Medicare Advantage supplements have included family caregiver support services, some of the Medicaid health and home and community-based waivers. Then there's the Older Americans Act that had National Family Caregiving Support Program, Title E. And then there'll be more and more. The Lifespan Respite Care Program is an important one to know about, which comes through our Administration for Community Living in the U.S. Department of Health and Human Services, which supports 45 states in providing lifespan respite systems. Then there's Community Care Corps, a national program that fosters innovative models with local volunteers. That's coming from the national government. And just one more slide. And here's just an example of some of the caregiver training services that are in the new physician fee schedule. These are very important. CTS, we're referring to them as, and there's CPT codes and descriptions for each caregiver training service covered by Medicare Part B. Covered being done by a nurse practitioner, physician's assistant, clinical nurse, specialist, clinical psychologist, social worker, physical therapist, occupational therapist, you name it. So these are really just being rolled out, important to dig into. We continue to dig at Rush and to figure out how, when we're rolling out C4C, how future institutions that we're rolling it out to can best utilize these training services codes. Now, Diane will talk about how we're supporting family and friend caregivers through the Caring for Caregivers model.
Thank you, Robin, and thank you, Ronnie, for kicking us off. So appreciated. So becoming a caregiver, as you can see on this slide, caregivers are very diverse. And many of us do not even relate to the word caregiver, right? We're daughters, we're spouses, we're friends, and we're providing assistance in a variety of ways. But often, caregiving in that role of a caregiver or just the assistance that you're providing it can happen very subtly, right? It could happen maybe acutely in a crisis. It also could happen gradually over time with older adults. It also can come in cycles where you're providing some assistance and there's functionality returns and then something else occurs. So it really is varied also. So there's just a variety of ways that family and friends are supporting older adults. And so it's important to really understand how widespread it is. That oftentimes it can be younger adults. We've engaged with in our program grandchildren that are supporting their grandparents. So it really, is it doesn't look what we might think it looks like. It's just really across the board. Additionally, about 53% of caregivers that have been surveyed reported having no choice, meaning to say, now that sounds kind of negative, but meaning, for what the circumstances are, could be culturally, could be their, proximity, but it was just kind of occurred. And so again, could be in crisis. So feeling like it wasn't something that was planned out or thought out, or, we're not really accustomed to doing that. So it's just one of those things. It's a role, unlike any other role, where it's very unplanned oftentimes. And so that just comes with a lot, just by the very nature of it. Next slide, please. So, Ronnie and Robin both alluded to, within healthcare systems, right? We're very used to addressing our patients and providing the best care we can for our patients. And the patient is the person, of course, sitting in front of us with the chronic conditions or the acute crisis or whatever it is. But they often older adults are accompanied by a family or friend that's providing that assistance and support for them. And we're not really including them, maybe noticing them, identifying them, and certainly not assessing their needs and supporting them. In fact, less than a third of family caregivers say that a member of the care recipients' healthcare team has asked them about the support they need to provide the care for that older adult. And an even lower percentage of healthcare providers are asking what the caregiver needs for themselves. So those are just the statistics. They're low because historically that's not what we've been doing within the healthcare system, right? We're addressing the patient and not necessarily the group of, the one or two that may be accompanying and supporting that patient. Next slide, please. So caring for caregivers at Rush was created to address these concerns, to address really how caregivers are even identified within the health system. So are we seeing them? Are we noticing them? Are we realizing how important they are? Are we identifying them, which includes also in the electronic health record? So we wanted to really affect system change and start identifying and including caregivers in the healthcare system as a healthcare team member. The second part of our goals for developing this program was to provide direct services and supports then for those family caregivers to really to increase and support their physical and emotional health and well-being. Next slide, please. So you've kind of heard this mentioned already, but caring for caregivers is rooted in the CARE Act and the forums of age-friendly health systems. So again, that CARE Act enacted in 45 states and territories. So it's really very widespread. For most of the states, we've had that enacted for many years. Many of us from somewhere between 2017 and 2019. There's been a few that have come on board more recently, but it's been around for a minute. But are we really following those three standards of care that we are required to by state law to do? Are we really asking each and every patient that's admitted into the hospital if they have someone providing assistance or if they want to identify a caregiver? And if we are asking that, are we recording that in the electronic health record? And then if we take it a step beyond, are we recording it in a place where anyone else can see it, or is it only for that period of time or for that episodic experience with that patient that caregiver is identified? And then thirdly, are we offering and providing training for that care and support that they'll need when they go back to provide care for that older adult in the home? So it's very unclear right now how that is happening. Is it happening consistently, systematically? We're assuming that it's happening, but to what degree? Happening.
Diane? We're having trouble hearing you.
Yes, I think Diane might have just frozen for a moment. Wondering if Robin, until
Sure.
Diane comes unfrozen, if you,
Of
thank you.
course. So I think I mentioned a lot of this in the forum. Diane, you're back. Go ahead. Oh, it went away. Okay, let's skip to the next slide. So some of the key identifiers of what, Diane, you on? You're on mute.
So sorry, I don't know what happened. All of a sudden you were all gone.
Okay, go for it, but I'm hanging in the background. Go ahead.
Okay. All right. So I think I last was just talking about the 4Ms. So the 4Ms framework for older adults. For the Caring for Caregivers model, we've incorporated that and we address the 4Ms with caregivers as well. Just as important for our caregivers to be looking at those 4 important factors as well. So the key areas of Caring for Caregivers model: identify, understand, and assist. We want to identify and record family caregivers in the older adult's health record. We want to be able to identify that very clearly in a way that can be seen across care settings. So at Roche, what we do is we have Epic, and if you open an older adult's patient storyboard, right in the left-hand corner where you see a picture of the patient, you get some of those identifiers, date of birth, etc. Right below that, it has a field that says very clearly caregiver, and that is where a named caregiver resides. If you hover over that field, that will take you to another area of Epic that then gives you an opportunity to provide additional information about that caregiver that is very important for healthcare systems, such as, is this caregiver also the healthcare power of attorney? Is this caregiver also a guardian for this older adult? So those are really important factors. And because it's right on the storyboard, when you open a chart, every provider across that hospital setting can easily identify that caregiver. The second key area for our program is understand. We want to understand. Caregivers are diverse, right? Every situation is different. So we want to understand and assess the needs and the strengths of that family caregiver and the care recipient using a strength-based approach. The third thing is we want to assist, right? So we can't just understand what they're going through, assess needs, and then not address those needs effectively. So based on what matters, and the identified resources, we identify resources and we develop an individualized person-centered plan of well-being for that caregiver and care recipient. Next slide, please. So how do we do that? We begin with what we call a getting to know you meeting. So it's really a conversation, and it's a caring conversation, right? So caregivers are not normally addressed. They're not usually asked how they're doing. They're not asked about their role. And so this is the opportunity. That's what we are charged with doing. So we want to understand, we want to let them know that we are there to support them. And so we're having a caring conversation, which includes a series of evidence-based screeners. So we can really hone in on their needs, their strengths, and understand their caregiving situation. So we get to hear about, like, are they living with the older adult? Is there a distance there? Are there other family members or friends that are providing support? Are they alone in their caregiving role? And also, what is the emotional impact and health impacts that they're feeling at this time in their role? So as you can see here, many of you are familiar with the PHQ, the GAD-7 within healthcare systems. The burden scale for family caregivers really hones in on and helps caregivers self-identify, and I'm going to show that in just a second. We also do a brief health literacy screener because we really want to find out where they're at with health literacy so we can support that and provide information in a way that's going to be understandable and effective for them. Of course, we screen for social determinants of health, and we do a full biopsychosocial spiritual assessment. Next slide, please. So I really wanted to show this particular screener, as many of you are not familiar with it. This is the burden scale for family caregivers short version. And if you look at some of these questions, I think what happens, what we find happens with our caregivers when we start asking this and having the conversation around these questions, it really helps them often self-identify with, maybe not as the label of caregiver, but that caregiving role and what it might be, how it might be impacting them. So my life satisfaction has suffered because of the care. And even if, sometimes it may take a minute, like, oh, and then you have to think about it. And then there's a conversation that kind of comes with that sometimes, they'll kind of talk it out. I often feel physically exhausted. We strongly agree on that quite often, and so on. And it really just gives them that opportunity. We often hear, gosh, nobody's ever asked me these questions. And sometimes that'll even elicit an emotional response because somebody's actually taking the time and asking about them. We sometimes also hear caregivers ask us, oh, you're talking about, my mom, right? You want to know this about, what's going on with my mom. No, this is about you. So it's just that opportunity to really build that foundation of understanding and support. Next slide, please. So we've identified caregivers, we've understood them through our caring conversation and a host of screeners that have identified needs and strengths. And so then we develop an intervention plan that works for that individual. And it could involve one or all of these various intervention components in the C4C model. The first one is what we call skill building meetings. And those are currently referrals to various other professionals to, again, support the well-being of that caregiver and or increase their confidence in the care they're providing. So I'll give a quick example. A caregiver might be helping their older adult transfer in and out of a wheelchair or in and out of bed, etc. So there's lifting and logistics involved from a variety of settings. And so they may have never been kind of shown or nothing has been demonstrated how to do that where they're taking care of themselves safely, they're not harming their own self, and are they keeping the older adults safe? So they may be a referral for an OT evaluation. Could be also they've reported that they are doing those transferring, but they feel like they've really strained their back, or they notice that they've got constant back pain now. They think it's from that. They may be a referral for a PT evaluation. The middle component that you see are planning for what matters. Those are brief psychotherapy sessions from 1 to 5 sessions and really very individualized. And this is really kind of the heart of our model. Because it's very individualized, we get to really talk one-on-one with the caregiver and hone in on those topics that are most important to them, what matters to them and to that older adult. The third component is care team planning meetings, very similar to a goals of care meeting within a hospital setting, where you're just gathering that care team, primary, specialty, home health if they're involved, caregiver, care recipient, and ensuring that what matters to that dyad is involved and is really at the center of the goals of care. Next slide, please. So I want to show our outcomes because we do rescreen for depression, anxiety, and burden at 1, 3, and 6 months post-intervention. So once we've completed that individualized intervention plan, we rescreen. And as you can see here, we do see decreases in burden, anxiety, and depression across the board. Next slide, please. We also took a look at, do we have any impact on the care recipient's health or utilization of hospital, which is very important to healthcare systems. So what we did is for those caregivers that went through our intervention and had a care recipient receiving care at Rush, we looked at 6 months prior to the caregiver intervention, utilization of hospital, and 6 months post. And as you can see here, we saw very drastic reductions in inpatient days, stays, and ED visits. However, we don't claim causality, but we see there's a strong association for if you're caring for that caregiver, the chances of the older adult decreasing utilization of hospital is likely. Next slide, please. So the model is adaptable and sustainable. I think that's a key component to take away here when we look at, implementation. This is about implementation strategies. We developed this to be adaptable, and we learned a lot when we pilot tested our model in those various settings. So we wanted to make sure it was adaptable. The model is the model, but it's not just this is what you have to do, and it's very prescriptive. This is about collaborating, utilizing the resources you have within and within the community. And services can be billed as part of the usual service line through the psychotherapy and other codes, or through community clinics that can offer those planning for what matters psychotherapy sessions. So a variety of ways it can be adapted to your setting. Next slide, please. The billing is done through the caregiver's insurance generally because the caregiver is our patient. We do open a chart for that patient if they're not receiving care at our healthcare system. And the billing for service is done using billing codes through private insurers or CMS insurance plans. Next slide. As we share the model across age-friendly health systems and area agencies on aging, we do offer full training model. These are the training materials that we offer to sites when we provide training. We have a full playbook for clinicians, administrators. We have a manualized version of our Planning for What Matters sessions that is used as a tool for clinicians and a guide. And then we have a caregiver workbook that we also provide. Next slide. And then we also offer a 4Ms caregiver facing brochure. So this is for caregivers, about caregivers, and it's about their own taking care of and looking at their own 4Ms, as well as considering the 4Ms of the older adult. Next slide. And I want to thank you so much and open to all your questions. And I'll pass it now over to Dr. Cohen. I'm sorry, to Vivian Joy, who is a family caregiver and also a nurse at Rush. Thank you.
Hello, everyone. Could you guys hear me okay?
Yes.
Okay, great. I'm calling from Florida, here with my parents visiting from Chicago. And I am very grateful that I have encountered, met Stephanie, and the Caregivers for Caregiving program has been very beneficial to me. And I had actually participated in a few of the group coaching calls. And I also initially started out with a couple one-on-one sessions with Stephanie. So being a nurse in a medical intensive care unit, you kind of have an idea, where your loved ones, well, my parents, my dad just turned 80 yesterday, so feel very, very blessed to celebrate my birthday, my father's birthday, and my mom is actually a retired nurse, and she'll be turning 80 next year. So, but there's a lot of emotions that we go through, and as a healthcare provider and a caregiver, it's kind of like a mixed emotions. But what I felt like when I was talking to Stephanie at the beginning, you feel like you're being heard, and I love the caregiving communication as well, and it feels like that you're you try to stay strong because, okay, I know this, I know how to navigate the healthcare system. And sometimes when you know too much, it kind of like increases your worries and fears or either anxieties. But the resource, there was a resource PDF that Stephanie has given me, really helped me plan ahead. And actually, even though, depending everyone probably has a different level journey. You may be like in a crisis or just planning ahead. It's just best to like, even though life gets overwhelming, it's just best to actually find some time to look at all the resources and plan ahead and see who your support system is, family, friends, and also, your, what do you call it? Yeah, family and friends. But going back to the support group system, you listen to other people's stories and you feel like you're not alone in going through this challenge. And also, when you hear other people's stories, you find some wisdom and some strength to other people's stories, and you could also plan ahead that they may be advanced in their journey with their elder parents, spouse, or loved ones or friends, and having that space to share is so comforting, and it's very helpful because sometimes you may feel like you're alone in your situation, or for example, I'm single, no kids, so because of my flexibility, all of my siblings are married with kids, so it's hard for them to just get up and go and help my parents. So physically, one person may have all put in more, but into the situation of caring for someone. But it also, when you listen to people's stories, you have a better understanding what the other people is going through. So no matter what, it's going to be a challenging situation, but the best thing to do is to reach out, even though you are in an okay place, but it's best to plan ahead and just find some time, at least a half hour, an hour, to go through this playbook, because it's better to plan ahead. And when all of your emotions are like, not in a crisis mode, you could actually think more clearly, plan more clearly, and plan ahead. And once you get that out of the way, you'll be able to enjoy, time with your loved ones as much as you can. And obviously, it can get pretty stressful because everyone has different perspectives about the way things should be done. So yeah, I highly recommend this program. I'm very, very blessed that we have it. And yeah, that's all I could say at the moment for now.
Thank you so much,
Thank
Vivian.
you.
We really appreciate you joining while you're celebrating your dad's birthday, and just really appreciate your perspective and insights from the experience that you have. So I will next pass it over to Dr. Gabriella Cohen. And I'll just say thank you all so much for the questions that you're submitting. We'll do our best to answer as many of them as possible. We're excited now to hear about the experience of addressing caregiver needs at Grady Health. Welcome, Dr. Cohen.
Thank you so much, and thank you so much for the invitation. I wanted to share a little bit a research that I did a year and a half ago with the patients that we see in geriatric clinic with comorbidity and dementia. And after I show you the results of my research, it was a really good idea. And I think that partnering with this amazing program for caregiver education will definitely align with what our patients and caregiver needs, and we'll be able to help them a lot more. So comorbidity and dementia means when a patient has dementia and any other diseases. And sometimes dementia is just a list on a long list of different medicines. And that usually leads to fragmented care. That means multiple different providers, multiple visits, conflicts with the medicines. And sometimes this is challenging to practitioners because we need to build out a plan that is very flexible, that includes all these different diseases, that considers the prognosis, the severity of the dementia, And it's very important to take into consideration what is significant for both the patient and the caregiver. So we build this plan that hopefully will kind of consolidate this complex care and really help patients and caregivers. And of course, identifying caregiver distress and treating is a fundamental part of this plan of care. Next one, please. So let me tell you a little bit about Grady Memorial Hospital. So we are located in Atlanta. It's a 953-bed academic hospital. We serve a large population, mainly of African American, and also a small percentage of Latino population. And these patients are usually from low income, very diverse, underserved population. We work physically in the geriatric clinic, and we see these very complex and frail patients with all different diseases and with multiple health transitions. These are patients who go from the emergency medicine to the inpatient to the outpatient. So they have all these different encounters with the health system. Next one, please. So what we did is we interviewed 20 diets of patients living with dementia and comorbidity and their caregivers. And we did, of course, a dementia-specific interview. We made a very detailed review of the medical records. We did a comprehensive geriatric assessment. And then we added this kind of semi-structured qualitative interview where I was speaking with the patients and with the caregivers, trying to see what is significant for them. Are we offering the plan of care that is really significant for what they need? Are the caregivers stressed? What is the logistics of the day-to-day? What is the routine during the day? How many times the patient is taken from the geriatric clinic to the emergency room? How many admissions during the year? So we try to do a very inclusive detail, and the focus of this research was what is really significant? Are we doing what is significant for the diet? Are we really helping? Next one, please. And based on that, we have this population, and I show you a little bit my research. Most of the patients were female. The mean age was 74. All the patients, of course, have dementia. 11 have Alzheimer's disease. 7 patients have mixed dementia. 1 patient have vascular dementia, and 1 patient had Lewy body dementia. As per the staging of the disease, 35% have mild dementia, 45 had moderate dementia, and 20% have severe dementia. As for the caregivers, they were all family caregivers, non-paid family caregivers. Most of the caregivers were females, and they were all related to the family related. Yeah, good. This is it. The age of the caregivers were from 30 to 49. We did this scale that Diane was mentioned before to see what was the burden of the disease on caregiver stress. And it was interesting that on this scale, the scale result was not very high. So we have a mean value of 14 that usually not related to very high stress. But when I was interviewed the caregivers, just talking to me, most of the caregivers were super stressed. Next one. So we were trying to assess what is significant. So for the caregivers, what was really significant for this population was to get more help at home, to improve the functional independence, to decrease the burden. And it was very important for them to consolidate care with one primary care doctor and to avoid all this care fragmentation, all this moving from one doctor, from one specialty to the other. All caregivers found that this discussion, having time to discuss what is really significant and talk about caregiver stress, was very helpful. And what we did after having the discussion, because of course we need to align with what is significant for them. So mainly we ordered home services. We did a lot of interventions to decrease caregiver burden. And I'm happy that we're going to partner with this model, and we're going to continue to offer caregiver burden strategies. We manage comorbidities in the context of dementia in 45% of the cases. And it's interesting that after the discussion, in almost every case, we did 2 or more interventions. So having this discussion and seeing what's really significant really open up and hopefully help us design a very personalized plan that considers what matters most. Next one. And thank you so much. And I guess we'll have time for questions. Thank you again.
Thank you so much, Dr. Cohen, and thank you to all the presenters. We've been receiving a lot of great questions, and what I'll do is invite all the presenters to come back on screen and invite you to respond to some of the questions we've received so far. So first, Dr. Cohen, I'll just ask kind of what led you to the decision to implement caring for caregivers at grade 8?
Yeah, that's an excellent question. I think that this is what the families need. And I think that partnership and having time for assessing caregiver stress and caregiver education will really align with the 4 M's, with Grady being a friendly, academic and proven friendly system. And I think that this could really help us provide with what the patients need. And especially after the research, even when we're doing these scales, we don't think the scales numbers are very, very high in caregiver stress, but when talking to these families, almost all the cases, they really need more help. So this will let us continue and have more social involvement. So that really aligns beautiful with us.
Excellent. Thank you so much. And we received some questions from participants sort of asking about how the model is adaptable for different communities, different populations. There was a question in the chat about adults with serious mental illness. So I'm wondering if you can speak a little bit to some of that kind of community and population specific adaptation.
Thanks, that's a great question. Oh.
Sorry, you're asking Diane or you're asking me? Sorry, I missed that.
Oh, sure. I think on this question, I'll tee up for Diane to speak to first. Thank you.
Thank you. So again, when creating this model, we wanted to be able to address diverse needs, right? I mean, we're part of a very large hospital system. We are situated in the west side of Chicago, which is really a very underserved area. And Chicago is very diverse. And so we thought about that going into it and the reason we use licensed clinical social workers to provide the intervention is because of what social workers offer, which is, we look at things holistically, we look at things individually, we're person-centered. So we're meeting the person where they're at. And part of what our ongoing training and our foundational training is cultural competence and cultural humility. It's always there, and we're always adding to that and learning about it. Specifically as well, our team at Roche, we engaged with the Diverse Elders Coalition. They offered a specialized program, a training session. It was 5 sessions on serving diverse caregivers. So we're always looking for adding on and better understanding. So really, because it's individualized, you're really working with the person in front of you and what they bring, and then you adapt your intervention for that individual and what they bring to the table.
But I'm hearing also kind of a desperate piece in the Q&A saying, come work with my population. I'm caring for somebody with a disability with mental health issues. And I think it would be very applicable. And we should all be advocating as a coalition. And I think we'll even get it further along.
Wonderful. Thank you. So I'll just say that as you were presenting on the caregiving assessments, there were a number of people who posed questions about, who are really enthusiastic to learn about these and wondering kind of whether they're new to the field and how they're being supported and implemented throughout the healthcare field. So I'm just wondering if you can speak to the landscape for these kinds of assessments.
So is the question particularly, let me just be clear, are they about those assessments? Are those assessments readily available, or how are they utilized? Are they utilized heavily?
They're saying that they've been caring for their child for 40 years and no one's ever asked them how they're doing.
Yes.
It's not okay practice, and we'd love to help influence a change.
Absolutely correct. And that's really, again, one of the reasons we're doing what we're doing, what this model is about, is because caregivers aren't being addressed, and that the caregiver role is not being addressed. So maybe my health is, but I'm a caregiver, and my caregiving situation, and like that example, affects everything, right? It affects my mental, my emotional, my financial, etc. And it should be included and addressed by my healthcare providers.
Thank you. I'll ask a few other quick questions. One is sort of someone asking about how that engagement happens. Is it in person? Is it by phone? Is it virtual? And then also some questions about peers and whether kind of peer-to-peer learning and support and how that might fit in.
Absolutely, both great questions. So the peer-to-peer is definitely available. I know that's really important to some folks. So again, we're assessing individuals, and we kind of determine what would work best for them. So we do offer a peer-led support group at Rush, but we also are in touch with the resources available in our community, right? So we know what's available, and so we connect caregivers to those resources that kind of best fit their needs. So that's kind of where we're at as far as peer-led. We don't, yeah, I think that's question. And I'm sorry, what was the first part of that question?
Just about in person versus
Yes,
phone and
yeah.
virtual.
So again, kind of meeting the person where they're at, and kind of knowing that most caregivers, they're already burdened and their time is tight. We do offer, by telephonic, we do virtual visits, but we also do in person. So it's really up to them on what works best for them and their time. I think that's an important piece too, because it's really helpful for caregivers if they don't have to go through now the burden of getting transportation and coming to the location. So, and then others want to do that. So it's available.
Wonderful. So we just have one more time for one very last, probably 30-second answer, which is Vivian Joy, I'm wondering if you can just speak to if there's any kind of last thoughts that you sort of would like other healthcare providers to know about the Caring for Caregivers model.
Yes. Can you repeat that question again? I'm sorry.
Oh, sure. Sorry about that. Just if any last, is sort of in 30 seconds or less, any sort of final thought on, from your experience as a healthcare provider and a family caregiver, what you'd like other healthcare providers to know about the Caring for Caregivers model.
Yeah, it's okay to reach out. I know sometimes we're like, okay, we got to handle this because, I know how to handle that. I know how to navigate the healthcare system that, but we're just probably have so much information overload, but it's best to reach out to the people at the program, because they could give you different insights and different perspectives that you may not be aware of. So yeah, just reach out. It's best to do it way ahead of time versus like wait for like last minute thing when you're actually in a crisis. Yeah, it would just be they're very resourceful though. Like for example, if you have someone in a different state, a loved one in a different state, they will research it for you because, my parents are in Florida. And it just makes it a lot easier for you to because sometimes there's some information overload on the internet, and Diane and Stephanie gave me some resources. Now I could actually go directly and call the people now to plan things ahead. So just reach out no matter what.
Thank you so much. I feel like we could probably keep going for much longer, answering questions and kind of talking about the importance of this work. We'll pull up the slides and just wrap up. And I'll note that I know we referenced a lot of resources today. On the slides, you'll see some of those resources linked, and we'll be sending everyone a follow-up email, and you'll see links to a number of other resources. And what we'll do is add in a lot of the Caring for Caregivers resources that were mentioned today. On the next slide, I'll just note that if you have helped to develop evidence on what works, we would welcome you to submit your resources, your ideas to the Better Care Playbook. You can see the link there. And as a reminder, please fill out the survey that will show up on your screen. We really value that feedback. And thank you again to Ronnie, Robin, Diane, Vivian Joy, and Dr. Cohen, just for sharing your learnings, your expertise, and your insights. I also want to thank the Seven Foundation Collaborative for supporting this webinar, and everyone who joined. Thank you for all of your wonderful questions. Again, thank you all, and have a great rest of your day.
Thank you, Logan.
Thank you all. Appreciate